This we did try and do this session, I think, in a rapid, opportune window, which then suddenly became half term. So we only had one person turn up. So it's really helpful, reassuring, and exciting to see so many other people turning up. I'm not going to waste a lot of time making an introduction. My name's Richard Brownell. I'm an improvement manager with the Emergency Care Improvement Support Team. My background's emergency care. Slightly more akin to looking at streaming through a workforce lens. And my colleague, Rob Penati, who's here, is going to, as one of our clinical associates, who's a nurse consultant at UCLH, is going to probably start us off and take us through some of the content that we're talking today about, which is streaming and triage. So often people use these terms interchangeably. We've seen many iterations of initial assessment, for want of a better term, as we go through organisations, UTCs, EDs, and it is a bit tricky, and there isn't a one size fits all, but there are some principles that hopefully we thought we'd start with for the first maybe 15, 20 minutes, and then give over to you guys to, let's share some ideas and see where it takes us in terms of any support that we may be able to help with, or indeed any stuff that you're doing that everybody else needs to know about. So without further ado, I'll hand over to Rob. Thanks for coming. If you want to put your hands up and ask questions, obviously please do. It might be better to do it at the end of the presentation when we're going to have an exchange, but if it's a burning question or you don't understand some of the terminology, for example, then please don't be scared of doing that. We'll happily take questions as we go through. Thanks then. Over to you, Rob.
Thanks, Richard. Yeah, good afternoon, everyone. So as I don't even need to say who I am because Richard's done it beautifully for me. Just to let you guys know, we are recording the session. I'm sure you've already got the little banner on the screen just to tell you that we're recording. So it's just to let you know. Hopefully you can see that presentation. I'll go into presenter mode. Bear with me. There you go. Richard, I can't see hands when I'm presenting from this end, so just let me know if there's hands.
Yeah, got it.
Okay, so as Richard said, really this is about us wanting to spark debate and discussion and learn from each other about what we're all doing. I am going to share what we've done at UCLH, but it by no means means that is the one and only version of the truth, and this is the way that we should all do it. It's just that my own personal experience. I hope that helps to bring some of this conversation to life. I thought I would start actually by if I can get my slides to advance, is just starting with some definitions, which sounds a bit boring, I know, but actually everyone or very many people are familiar with this document. This was published in 2017 by the Royal College of Emergency Medicine and really sort of set out almost like a blueprint really in terms of the terminology that's used. However, that has now been superseded. So the Royal College of Emergency Medicine, NHS England and other bodies have worked together to develop the most recent guidance, which was published in 2022 August. It's available on the NHS England website. There is a link there, but basically if you just Google initial assessment, pretty much always this is now going to be the top hit, with RChem certainly second behind that. So this guidance now supersedes the RChem guidance, and I think it's just trying to clean up some of the terminology. For those of you who know the RChem guidance will know that that refers to simple streaming and complex streaming, and there's various other bits in there. So this is kind of a simplified perhaps version, and we can get into the whole detail about whether maybe it's too simplified. So a lot of this is absolutely copy and pasted very deliberately from the document, from the website. So I've just said it. Essentially, this is setting out why this new guidance has been developed, and it's because of some of the confusion and or inconsistent use of terms. I think that still pervades, but we can get into that. And essentially what it's saying is can we just look at the initial assessment component, which actually could be also including streaming, triage and RAT. So I will go through each and every one of those terms again based on this guidance. And the idea is that you go through some sort of initial assessment as a patient, and then a decision is made. And in this infographic, again taken directly from the website, it suggests that you could end up in either an emergency department, UTC, ESTEC, So pretty much generally all on-site type services, or you could go to an off-site service, and we often refer to that obviously as redirection. So let's get into the kind of detail with all of those terms that we've just quickly whizzed through. So initial assessment, I think we're all very familiar with this. This is the idea that the patient will be initially assessed within 15 minutes of arrival. There are two main factors, again, according to this guidance, which is that really it should be about the chief complaint or suspected diagnosis, i.e. what is the primary problem, but also acuity. Now, this is where it starts to get a little bit kind of grey, because what do we mean by acuity? Well, again, from the document, from the website, this is what they mean by acuity. So you'll see on the left-hand side, ECDS coding 1, 2, 3, 4, 5. For nursing staff, for staff that regularly apply a acuity assessment, be it a triage assessment like Manchester Triage or other tool, we're very familiar with this idea that we have a score between 1 and 5. Just to give you some context, the A&E coding in the background is 1, 3, and 4, resus majors and minors. What the document also says, and it's at the bottom of the screen, is that initial assessment must add value. So it shouldn't just be a process by which you say, well, I've done my initial assessment, chief complaint and acuity, and then nothing really happens. It should add value to the patient journey. And that's where I think this starts to overlap with the other terms, which we'll get to in a minute. Hence, they've put all the terms kind of together. So streaming, I alluded to how previously we talked about simple and complex. Well, now this is kind of the definition of streaming. So it's an activity to direct patients to the most appropriate service, okay, based on their presenting symptoms, chief complaint and acuity. So initial assessment, as we've just defined it, is absolutely part of streaming, okay, because we're still doing the acuity and we're still doing the chief complaint. However, there may be a bit more to it than simply a chief complaint and acuity. You are starting to take a bit of a brief medical history, doing some basic observations. You may use an early warning score, and so on. I guess as a practicing emergency nurse of many, many years and having triaged who knows how many patients in my career lifetime, certainly with Manchester Triage, which is what we use at my hospital at UCLH, University College London Hospital, you can't complete Manchester Triage without doing some observations. So we see it as an embedded part, actually, of what we do at the front door, which I'll come to in a minute. Okay, so then why is triage different? Well, we know that triage is to sort, and it prioritizes patients based on perhaps a more fuller assessment, or before a full assessment could be carried out. So in other words, we have a demand on our department and we cannot meet that demand, i.e. patients can't all be seen within a set period of time. So we must be able to identify the sickest patients and prioritize those first. I think I'm going to propose that sometimes the reason why triage gets used interchangeably is because triage in many departments is also a place. So it's not a process, it's a place. People talk about, can you please put a tannoy call out for a porter to come to triage? Or we talk about, you know, can so-and-so go to triage, or can we? So I think people get, the term gets mixed up because actually it's a place. And often it's a place, it's a room with a nurse or an HCA or both in there, and things are happening to the patient. So it's more than just actually applying an acuity or a priority score. As you saw in right at the beginning, it does also refer to rapid assessment and treatment. Why? Because actually some patients, and in many departments, it will be ambulance-borne patients. That is the process by which they are initially assessed on arrival. Of course, that also includes clinical handover and offload, etc., etc. So often there will be senior decision makers involved as well. But in many departments, actually, it's nurse-led and nurse-run. The document says the RAT is the most complex form. It incorporates streaming and triage, so it's kind of wrapping the whole thing up into one big bundle. So if I just flick back, we've gone through initial assessment, RAT, triage and streaming. I'm going to propose to you that actually in many departments, and it's possible actually to do pretty much all of it all at the same time, rather than them necessarily being distinct and separate steps. And of course, what I'm going to do is then stick my head above the parapet and give you an example. So this is where I work. I've worked at UCLH as a consultant nurse for a little over 6 years now. Prior to that, I worked at King's College Hospital as a consultant nurse there for 5 years. So we've been on a really long journey in terms of developing the urgent emergency care floor at UCLH. So this is by no means something that's happened overnight. This work started well before COVID and through COVID and continues today. So go back pre-COVID. Few things to point out to you, because this is obviously a very busy slide. So essentially what we did is we tried to sit down and actually map what happens to patients in our department. This is pre-COVID, this is a few years ago. And very quickly, we realized that it was complex, to say the least. And actually, we could have drawn more arrows on this and probably had more boxes. This is kind of a cleaned up version, believe it or not. We did this as well. The context that you should understand in this is that this is before we had a fully digital system, which we have now, which does make a big difference in terms of some of the processes. So this was essentially a paper-based system, which many departments still are. So let's follow a typical patient journey. So if you're a walk-in patient, the first person you would have come to, bearing in mind this doesn't happen anymore, is what's dubbed the navigator. Actually, it's kind of a streaming, well, it is a streaming person. It's a nurse, it's a registered nurse, but the term navigator is stuck at UCLH, so we still use it today, which I keep trying to tell my colleagues to stop using that term. It's actually a streaming, but it's a clinical member of staff, and that person would take some details and start to think about maybe where you could go. However, in reality, what often would happen is that then they would book in. So there's a whole discussion to be had about which one comes first, booking in or the clinical interaction, or the other way around. In my hospital, it was clinical interaction, then book in. Then you'd go to the waiting room, and then from the waiting room, you would get called by the triage staff, so main triage, of which there were 1 or 2, and certainly 2 at busy times. We actually had the capacity to go up to 3. So then the patient would get up and go to that room, and then there's some more stuff would happen to them. So a full set of OBS and various other bits. And then the nurse may say, well, actually, I think we need bloods and we need an ECG or whatever. So then that patient would go, actually, I've shortened it, because it really, what would actually happen is they go back to the waiting room. Then they get called by diagnostics. And in diagnostics, it's a room with an HCA, healthcare assistant in it, who can do all of these things, so take bloods, do an ECG, etc. Then, if that patient's already been identified as heading towards majors, that patient would end up finally in majors. Now, when this was occurring, we were seeing between 90 minutes and 2 hours before the patient would actually arrive physically into the majors area. So it just gives you an example of how long that takes. Of course, from triage, they can also send to UTC. They could send to the GP service. Whilst they kind of resided in the same physical space, they were kind of seen as 2 separate entities. Okay, let's start again with ambulances. Ambulances would come in, they would go to the majors RAT area, and that team might say, well, okay, we'll offload you and you need to go to majors or resus or whatever. Or they might say, actually, I think you can go to UTC. And actually, what would sometimes happen is that patient would then have to go to UTC triage. So we had another triage, another nurse in UTC that would do another triage, even though they've already had a kind of assessment triage in RAT. So you can see where I'm going here. And that was to try and pick up some of these patients that might have, fallen through the net, as it were, before they actually physically get seen within the UTC and or GP service. You'll see that there are other ways out of the emergency department, and I won't go into those because they've changed dramatically. But that just gives you a sense of all of the steps. And actually, Richard and I are very fortunate. All ECIST colleagues, we're very fortunate because we get invited to walk around people's departments and try and help them to improve. And this kind of a map is not uncommon. That's certainly my experience, even today. So we worked I can't emphasize enough, this took 3 to 4 years, but we worked on cleaning all of this up, which means that we had to think about all sorts of different aspects, not just the front door. This is the system that we have now. So I'll just walk you quickly through it. You're a walk-in patient. You book in first because we're now 100% digital. So we actually book you in first, because if we don't book you in, we actually can't do very much with you in essence. You're then seen by, again, I told you the terminology stuck. So this is an old slide, but you see the streamer. And the streaming nurse does a set of OBS, chief complaint, assigns an acuity or Manchester triage score. You take whichever term you want, and then makes a decision about where you should go next. And there are fewer options, but actually there's more direct access, particularly for that individual. Straight into urgent treatment centre, and that is our GPs and our practitioners combined, so it's much more collaborative working now. Rapid assessment and treatment. So if you're a walk-in patient, even after you've been streamed, you don't go straight to majors, you still go to rapid assessment and treatment. And that obviously includes all the ambulances. So the ambulances go direct to rapid assessment and treatment. So you cannot get into majors without going through rapid assessment and treatment. And the navigator streamer can also send direct to ECIST. In fact, there's a couple of arrows missing here, because ambulances can now take direct to ECIST for heralded patients or referred patients and various other things. For those other patients that have gone through rapid assessment and treatment, then of course some of them, not all of them, will obviously end up in majors, but some will also go to ECIST at that point. So the ambulance offload, assessed, then a decision is made to take to ECIST. So what you'll note is that those things like triage, UTC triage, and diagnostics have disappeared. So where have those people gone? Where have those staff gone? Well, that was the big step for us, was to stop doing that thing, that process, and move those staff into RAT, enabling us to have a bigger RAT team. And we had a dedicated space, admittedly, which did help. And therefore, we could make this decision about actually all patients go through rapid assessment and treatment in this model, apart from those that obviously can go direct to UTC. So this is what it looks like. This is the adult entrance, where we do have a separate pediatric entrance and emergency department. Peds is about 60 children a day. Overall, anywhere between sort of 380 to 440 patients a day at UCLH, so that's including the children. We get about 60 ambulances a day, so a lot of patients coming through the front door. You can see the two streaming cubicles. They're what we call stand-up cubicles, and on the extreme left of that picture, you might just see that there's another computer on wheels. That's our backup third position, just in case we actually need 3 people at the same time. That's what the cubicle looks like face on. So they've got an OBS machine, they've got a sink behind them, there's escape routes, there's curtains for a bit of privacy, although we rarely use them because it's just a quick chat with the patient. And the patients don't sit down. They normally stood up, unless of course they can't. They get a SATS probe on their finger, tympanic temperature, and then that enables us to do the MTS with SATs and with temperature, etc. And that's what it looks like from the nurse's view. So she's got a phone right next to her. She's got various pathways and numbers and the good old vomit bowl ready to go. So that just gives you a sense, and it is relatively close to the patients, because obviously there's always a lot of discussion about privacy. We always offer the patients to if it's a matter which they don't want to speak about in that area, that we move them through to somewhere where we can take it in, do this in private. So it's just to give you an example, a working example. And the question I get a lot is, yeah, but this is great, Rob, but what does that mean? You have hour-long waits? So I looked this morning. We have Power BI, which is a fantastic tool, pretty much live data. So for the last 3 months, and I only looked at the last 3 full months of March, April, and May, combined, our median time to streaming is 11 minutes, and that's 24 hours a day, 7 days a week. And the numbers, the proportion of patients that we do within 15 minutes is 67%. So it's by no means perfect. But the 95th percentile was 33 minutes. So, it's not perfect. We've still got some work to do. But it's a consistent throughout that period. So actually, that's quite reassuring. So hopefully that helps. Just to give some context, I'm now going to hand over to Richard.
Thanks, Rob. So I guess Rob's talked a little bit about a methodology, and Christina, thanks for asking a question about if there's no way to stream to, is there any point really streaming? And I think that probably comes back to terminology. So I think all patients that present to the emergency department or the UTC need to have a formal assessment within 15 minutes. And that formal assessment is the thing we're trying to achieve. I think if you haven't got anywhere to stream to, that might limit or might change what you do next, or indeed where you send people to. And what I appreciate, and as you'll see as I talk through here, is it'd be dead easy if this stuff was not, was simple and not complex. But sometimes the estate's difficult. The purpose of this slide here, what impacts assessment, is to kind of talk a little bit to that. I often go around sites and ask people if they've measured their time of assessment. So how long does it take to shout the first person and then to be able to shout the next person, having done some form of clinical and technical entry? So that might involve you writing it down into a system, as well as having done some baseline observations and taken a little brief history. Lots of places don't measure it. So we've got one thing about it, you need to do it within 15 minutes. But if it takes you 15 minutes to do because you're going to fill in, a falls risk assessment, you're going to start putting a mental health risk assessment in there, you're going to do a pregnancy test in there. And I guess over the last 30 years, I've seen that we've taken this initial assessment principle and started using all sorts of terms, including streaming and triage. And all we've really done is add things in. And somebody said, oh, yeah, we want to do brief alcohol assessment. Can you do that as well? And there's a sense, particularly from serious incidents, that had this have been done when the first person saw the patient, we'd have been a whole lot safer. I think my experience would suggest that the amount of effort put into trying to do things at the front door right at the very first interaction is likely to do two things. One, increase the risk of error, because the individual is working really hard to process those patients and in quite difficult circumstances. And the second thing is that it will take a long time to do, which puts the individual again under more pressure. And by putting you under more pressure, you're at a higher risk of error, but also of burnout. So I think it's good to look at your process and say, what do we absolutely fundamentally only need to do in order to say, hey, we've assessed you and given you a sense of your priority. And that makes us feel better because you're more packaged. But also, I've then been able to identify the best pathway for you. So I think we almost need to just think about, are they the things we're doing? Now, I recognise that our physical environment might mean we need 3 spaces and we've only got 1. It might mean that we've got, we've got a huge glass screen to contend with because we put that up to keep ourselves safe. And actually, we've got to try and shout at each other through there. So even a 2-minute conversation becomes a 4-minute, very public conversation because everybody can hear the amplification of your own voice in the waiting room. So some of this is just maybe to guide us into thinking, not just what are we doing in the assessment, but how might we do it? What's going to help us? If you measure the time, and let's say it takes 4 minutes to be able to assess somebody, including the computer entry and call the next patient, then 4 minutes multiplied by the number of patients that hour that you can take from your own data gives you a sense of how many people might we need. So if you're seeing 20 patients an hour, it takes 4 minutes. We need a minimum of 80 minutes of nursing time. So that's more than one assessor. And I use that term on purpose because I'm not using the terminology where we'll fall into a trap. But we're going to say that that assessment will require 2 people. There'll be times in the day when that's a bigger number or a smaller number. And the other really critical thing is we don't usually work in teams where we've got immediate cross cover. So we may well go, oh, well, Jenny's gone for a break. And as a result, the queue will exponentially build up. So when you come back, you now need 3 people just to deal with the backlog. So it's really useful to get your business intelligence people to look at your hourly assessment, walk-in patients in particular, and look at that and maybe measure a few measures about how many minutes it takes. And when you put those two together, you've got a fighting chance of being able to match that demand. I'm very happy to share templates and things with people if that's useful. Stick your email in the box. We've also got tools and technology. So we've got challenges around if your computer system is configured to say that you can't proceed until you've ticked 18 boxes about, you know, a gaudy clothing risk assessment or some other nebulous thing that you've suddenly incorporated into your system, then that's really important. So we need to understand what's the simplest number of clicks and the simplest number of screens to just get us into that. So I know that's sometimes difficult to retrofit, but is really useful anyway. And for those of you that might be on the call that manage teams and may or may not do this directly, go and watch how hard this is for people to do, because I spend a lot of my days doing it. And you know what? It's quite impressive how resilient our teams are doing this and what gets in the way. Obviously, patient history, comorbidities, we might find out all sorts of other stuff. Do we want a load of social history at that point, etc.? Possibly not, unless it's relevant. There's something about ease of access to other services. So Rob described what was quite a mature and cooperative system that allows you to be able to say, I'm going to send a patient to same-day emergency care, and something will happen behind that push of a patient. So in some other systems, you may well just be, it's it, we're the ED. So really, we have to kind of suck it up and do what we need to do. But there is a serious point about clinical support in the sense that if I deem all my walk-in patients require, I don't know, a blood test, I need to have the infrastructure behind me to be able to do that. Because if I don't have, we just build a queue there. And that has a massive impact, again, on our overall ability to feel safe and manage our own demand and capacity. Give us the next slide, if you will, Rob. So it might be worth reviewing your layout. This is an example of a layout from one department, and you can see I've just drawn little pictures on there. I tend to draw little stick men on stuff. I'm quite visual, and it can be quite helpful sometimes too when you're either looking at your own ED staffing or you're looking at the space that you've got available to think about where's best to place some of these activities and why. The other thing you might see there is in this particular instance, you can see reception. And you can see two receptionists. And an example of a department I visited fairly recently was the streamer or assessment person sat in the middle of these two receptionists, listening to two people booking in. So again, the risk of error is huge. It doesn't matter whether you're a good, fast assessor or a slow one, because we tend to polarize people according to those things. The reality is it takes X number of minutes. But again, we may be trying to do too many things at the same time. And incidents happen because we're under pressure and because we make mistakes. But imagine the noise of those two people talking around you. So do think about where you're going to place your assessment, and do think about how that helps. Another site I was involved with moved their assessment to a computer on wheels in the waiting room, and they were concerned about violence and aggression in the waiting room. And they said in the 6 months that they've moved to this, they've moved from 40% of people within 15 minutes to 85%, and no episodes of violence and aggression. So sometimes it's quite interesting to do a test of change, just to say, let's give that a go tomorrow and try it a different way and see what happens. Next one, Rob, please. So the next slide is just an example of thinking through your process. And this was a process on a site in the northwest of England. So registration took 1 minute. The kind of entry took 2 minutes. Then somebody decided to put the central name band printer right in the middle of the department. So actually we spent nearly half as much time getting up and going to find the right patient's name band. Bearing in mind they're booking in 25 people an hour. So you've got this kind of cascade of things spitting out. So there's a risk again of we might not unite the right patient with the right name band. But by the time we've selected it and gone back, we've wasted half our clinical time. So I think, again, it's just about how do we optimize clinical time and give that back to staff, because this is a hard enough job in the first place. So just worthwhile having a look at your process. Thanks, Rob. Next one. And sort of where are we now in terms of where we're having this discussion, because we know this has been kind of fed by the ED WhatsApp group. They're very keen to have a bit of a chit chat about it. But there are two national pieces of work being undertaken by the national IUEC team, being led by them. So these are some strategic pieces of work that will culminate sometime next year. So there will be opportunities to feed in your experience and your thoughts. And the work is around streaming and redirection. So how do we do it? Where do we do it? Who's doing it well? And what are the examples? And something around acuity and prioritization. So recognizing the amount of time sometimes now we're trying to give people an assessment, but it's hard to see the wood for the trees. So if you've got 5 or 6 people, is there a better way of more rapidly saying, actually, you're really obviously unwell, go to the rapid assessment area and we'll deal with everybody else in a kind of slower track way. So some of you probably already do examples of that. Most of us would say, oh, that's chest pain, we'll pick that patient, pull them through and start to work them up. But this is a kind of more definitive way of doing that. So some work is ongoing just to direct you to, in the sense that we might want to consider that within our thoughts. Okay, I shall stop talking there. We're kind of interested really in your experiences and your challenges. So happy to open to people's thoughts, suggestions, even comments on whether any of that was vaguely useful. We've got a hand up. Christina, hi.
Hi, you're right. I'm one of the senior sisters down in the southwest at Torbay. So we do have obviously the elderly population, which takes up a lot of our majors cubicle spaces because of that reason. So we are this week, funny enough, having an ED focus week and looking at improvement initiatives as to things that we can control. So obviously we can't control the outward flow of our department, given bed capacity. So we're looking at internal processes as to what we can change. So there is a big focus in terms of triage. So we are currently in that process of collecting the data, with our trust improvement team as to the time wasted, looking at that process mapping. As I said in the comments, we don't have that UTC to refer to, but it is something which we're collecting that data to try and build a business case for. So we've been exploring, we've got a triage steering panel, been exploring different initiatives as to how we can, what is a triage, how we can meet that that part of triage. At the minute, our average is about 23 minutes for time to triage. So it's come down since we put 2 nurses out there day and night to improve. But we're just struggling as to, we can't seem to get past that point of doing a proper triage as such. There's no bit by bit before, which you guys have in terms of streaming. So I don't know if you've got any thoughts of how we could bypass that bit, really.
Rob, nodding.
Oh, so many questions.
Indeed.
So thanks for that. It's really helpful, Christina. I think it sounds great what you're doing in terms of you managed to reduce it, and the identification that two RNs have made a difference. I guess it goes, my immediate sort of thoughts are, it goes back to Richard's point, and I think it sounds like you're doing this, which is actually measuring how long it takes for each patient and it's from calling the patient to calling the next patient. So just to be clear, it's not the time with the patient, because sometimes there's this other time that is used up in between patients. So be really clear about what you're measuring. It may be that the number it spits out is actually 3 RNs, which is kind of scary, because it's like, where am I going to get those from? However, I think one of the key things, and this is from my own experience, is we looked at what is it that we want it to do. Call it whatever you want. And actually, we stopped doing a lot of stuff, and that's how we got the times down. So are you doing risk assessments? Are you having to do, or we often feel like we've been told that it has to be done at this point in the patient journey. That's the bit that you can challenge back on and say, well, actually, hang on a minute. The aim of this first step, this first clinical interaction, is to do X and to do Y perhaps, but certainly not to do A, B, and C. So being really clear about that. I think I think you do still have opportunities to stream by the sounds of it, although they're probably very limited. But there is still benefit in identifying even internal pathways which they can stream into, to say, actually, we don't need to worry about those patients per se. They will get picked up in the fullness of time. Nothing else needs to actively happen to them. Which are the patients that we actually do need to do something a bit more active with? But yeah, I mean, it's a fascinating, and I'm intrigued now. I'm like, I want to see your department and try and figure it out. But that's just because that's the way that we're wired. That's why we work for ECIST. I don't know if that's
and
helpful.
You're welcome to visit, you know, at any we need your help. But no, there is a big focus on that area, certainly, because the risk is so significant out in that waiting room, and it has, you know, recent incidents has highlighted that because of that increased time in triage. We were hitting like an hour, even longer at times, you know, and we have managed to draw that back. One of the things is which we've identified is certain individuals out there, so it's very much dependent on who you have triaging. So we're trying to do a bit of education around that, and I guess also the impact of, if we want to do certain tests, you know, request those tests at that point, does that then have an impact on that 4-hour breach target as well? So it's just trying to get that balance right.
So firmly in the nursing and HCA and allied health professional sphere, you can also look at opportunities whereby you take that off the nurses that are doing that initial face-to-face and give it to another team just slightly further into the patient pathway. So if you don't have a system like I've described at UCLH, fine. Are there opportunities to say, well, actually, that next step can be done by these people? They can then do the blood requesting and It creates a kind of a two-step process, but there may be other benefits in terms of allowing those individuals a bit more time and space, because you've already filtered some patients out. Some patients won't need to go there to that place. So have a think about that and see if there is something, because when we did it at UCLH, frankly, I thought the nurses were going to take me outside and shoot me, because I said, well, we're just going to take away diagnostics and triage, and I think they thought I'd grown 2 heads. But it's because we were moving that function, what happens to that patient, from one place to another, but actually bringing in other aspects which actually made it far more efficient.
Thank you.
Just, I guess, a couple of things on the back of that. So one is try and keep it as simple as you can. I think the benefit of having recorded and registered somebody, recorded them and given them some form of acuity assessment, means you've got a better oversight of the department, A. B, having the right number of people to do it is incredibly helpful. I think the nature of the beast is sicker people are walking into the ED. We know that. And they're staying longer in the ED. So I think there's a secondary piece about how do we keep our waiting rooms safe, because it isn't through triage or assessment or whatever. The initial assessment, I'm guessing, is really only to identify the potential for patient deterioration as quickly as possible. The challenge, of course, is if you sat there 6.5 hours, you may well continue to deteriorate, and we didn't necessarily reassess you. So I worry that in a number of organisations I've been to, the way in which we manage the risk of people sitting for a long time in the waiting room is a slightly different point to the nurse who assesses them was responsible for something that happened in the waiting room, if that makes any sense. So there's something about managing the length of time people are sitting in the ED, particularly where, as you've described, we can't necessarily use other space and process people. They remain in that unfortunate situation where they're sitting in a waiting room for a long time. And I guess historically, that would have been an easy, in our head, we tend to think that's the waiting room, that's the really serious stuff in the resource room, that's majors. Whereas in fact, a lot of our risk sits now in the waiting room, doesn't it? So very happy to have further conversations if that's helpful. Any other questions, anybody? Any other comments? Anything anybody's doing that's magical that everybody else here needs to know about? Or just anything nice to know about? I don't know. Stephen?
Yeah, hi. So we're thanks, it's really interesting. We're in the middle of a trial, if you like, a Princess Hello. And we recently got a RAT process, which is we put it in for all walk-ins and obviously our ambulances. So our process at the minute is patients come in, they check in, have a set of observations done almost on arrival. So that's probably one of the downsides that we are looking at, and we are part of an NHSE initial assessment pilot. We're one of the pilot sites that our trust all recommends. So that's quite exciting. Patients come in, they have their initial assessment streamed by the nurse to our UTC ECIST and have that full initial assessment, and we use Manchester. Every patient that's then deemed to come into the emergency department will then sit in the waiting room and wait to be called in to see our RAT doctor. So we have 2 middle grades down there that will then do a RAT assessment on each doctor. So they'll do the investigations, refer to specialty, etc. Some of the questions we've had from the pilot, from the clinicians, is does every single patient that walks in need to see that RAT doctor? Can we do things differently? And obviously sometimes build up, we do then have significant waits for that RAT doctor. Now, we've got a lot better, so we're able to do pretty much on arrival to triage 80% of our patients are seen and within 15 minutes, which is great. And we've got it down to an average of 57 minutes to see the RAT doctor, but there are times where that could be in excess of 2 hours. You've then lost it. So any support or ideas that you've got around that RAT process, definitions or a criteria, some as was previously just mentioned, it can be person dependent. Some of it is a RAT assessment, some of it's a full Clarkin, full history, full shebang, and then that's where we fall over. But yeah, any ideas or support around that RAT process and preventing some of those waits would be really helpful.
Okay, I'm going to answer first because RAT's Rob's favourite subject, so I know it will go into full RAT description mode. So I guess a couple of things for me. One is around what's that trying to achieve, and it sounds really obvious, I suspect, but there may be something about segmenting. Are there groups of patients who don't need to go through that process? Because if that's the limited constraint you've got of those people, you may have to make a decision about what's the best use of the time of those 2 clinicians to do stuff. So that would be a first thought. And I suppose the recurrent thing of things being person dependent. In workforce planning, we tend to include a plus or minus 20% factor because we know people are different. My urge to all of us is really that people might be slightly different, but if the process is better, well defined and clear, then the variation is reduced. So what you tend to find is the reason everybody's a little bit all over the place is because you're either intuitive or you're not, rather than actually you're highly skilled, trained, and the process is really clear and aligned for you. Does that make sense? So I think there's something here about when you design the process, it isn't, I will train Rob to do A, B, and C. It's kind of the discussion we're having here is what's the aim? What kit do you need to do it? There might be some training implications, but there's also how do I reduce the load on your brain to do this work? So some of us probably are more resilient than others, which is why there's variation. That's not a criticism. We all need to be doing something that task is easier to do. So I suppose it's just trying to get us to think a bit more broadly about not sticking something in somebody's hand and saying run with it because it's fairly straightforward. Right, Rob, off you go.
So yeah, this deserves a whole nother webinar, really, to be honest with you. But I think it's actually a very similar conversation to having one about the front door, and that is asking the question as to whether or not 2 clinicians is enough. It may not be. The rapid assessment and treatment team that we have at where I work, it can flex up to 4 decision makers. Now you might say, Rob, we ain't got 4 decision makers. But that's a whole different discussion because they're probably just in the wrong place and you can move them forward and then decisions are made earlier. But it may be that there's absolutely a challenge around if they're trying to do too much. So we started with a 1-page pro forma. We're now digital, so we have what's called a smart text. It brings up a form, so it limits how much it reminds you to be succinct, to be brief, and it's not going to be the only clinical assessment that patient is necessarily going to get. there are other processes which you can think of which might improve stuff. So actually what we found is some of the biggest challenges in rapid assessment is not the clinician seeing the patient, the senior clinician seeing the patient and making a plan. It's then carrying out that plan, doing all of those bloods, ECGs and bits and bobs. So actually what we're really focusing on at the moment is actually the nursing and HCA team in there, because it's they that get overloaded. I saw a question in the chat about RAT waiting room, or I think it was. We have a specific seating area within the rapid assessment area, which is for rapid assessment and treatment patients waiting for clinical assessment. So actually, in all truth, the nurses and the HCAs often start assessing these patients, start doing stuff to patients before I, as a consultant nurse and ACP, even get to them. Just to give you some context, we, as I said before, let's say 400 patients a day at UCLH, of which about 340 are adults. I finally have data, it's just coming through now, so I can actually tell you this with hand on heart. We rat 167 patients a day during the week, 24 hours a day, 7 days a week. So it's a really high volume, high intensity system. So there are all sorts of things that you need to consider. For example, most well-functioning RAT systems don't have decision makers in there for more than 4-hour stints. They rotate them. And I would argue you should do the same actually with your nursing and HCA staff as well. So again, it's just trying to think about some of those aspects which will impact that assessment area just as much as it will impact your front door assessment area streaming. So I don't know if that's helpful, Stephen, but it's just some food for thought.
Yeah, no, that's really helpful. Thank you. And I might pick your brains outside of this call about something as well, if that's okay.
Yeah, of course, absolutely.
Thank you.
Okay, any more questions? Great input so far. Really interesting to hear people's brains are stimulated. He says. Anything else, or are we done for now? I feel like an auctioneer all of a sudden, going once, going twice. Nothing wrong with that.
Just Richard in the chat says, Stephen, I think it's you that's put 2 middle grades, 2 HCAs that can do the bleeding and the diagnostics. I don't know how many patients you have going through that area per day. I think my RAT system would not function if it wasn't for the RNs. They run it. So we have a nurse. So just like we have a nurse in charge of majors, we have a nurse in charge of RAT. That's how much emphasis we put on it. It is a clinical area and it has to be run. So I would argue actually what we did is we said to the clinicians, we don't want you to try and run it. What we want you to do is go and see the patient. That's their skill. I want them on the bedside, laying hands on patients, and then requesting the complex imaging, making the referrals, all that sort of stuff. So I want them to focus on that. The HCAs can put a cannula in quicker than you can take a sharp inspiration of breath. So let them do what they're really good at. But what the nurses are really good at is managing those patients in that flow. And actually, they refer a whole load of patients that I never get to. Because if they've returned within a certain period of time, or they see that they're well known to a certain service or speciality, they're brilliant at just picking up the phone and going, can I refer you this patient direct from nurse-led referral in effect? So just based on what you've typed, I know that's very brief.
Yeah.
Just have a think about that.
Yeah, absolutely. So our nurse process at the minute is at the very front door. So as your map of your ED was quite helpful to look at.
Yeah.
Ours is observations, check-in, then you have your nurse stream and initial assessment, and then they would then do the referring to the UTC from our pods, ECIST. The patients that need to be seen after that, but that come into ED, will then sit in the waiting room and wait to be seen by the RAT doctor. And in RAT will be 2 middle grades and 2 HCAs. So the nurses are a step forward, but it might be that we do look at having that one step, if you like, rather than 3 steps, as you mentioned before.
Yeah, and we have nurses at the front and in RAT. So just think of, you might need to think of that as well. And actually what that does is it saves a whole load of time further down the track. So if you imagine the ideal, doesn't always work, is that in my department, you can't get into majors without going through RAT. So the kinds of patients, in terms of how they're packaged by the time they get to majors, they've got a gown on, they're undressed, they've got a name band on, they've got a line in, they've had an ECG, they've had an analgesia, they've had antibiotics, and they've got fluids going, and everything requested. So the majors nurses don't need to do what a lot of majors nurses do their entire career, which is that offloading an ambulance, doing an initial assessment, undressing the patient, doing an ECG, doing bloods. No, it's already been done. So majors becomes a continuing care area. It doesn't become a reception area, as in where you receive patients de novo. They come to you packaged, and so we did a lot of work around that to try and persuade nursing colleagues that actually the nursing load reduces but it doesn't disappear. You're just shifting it for earlier in the journey. So it's just something to bear in mind.
Yeah, I guess I just wanted to add that to the mix, in the sense that your sepsis bundles and various other things, the minute the doctor asks for something interventional, does that mean you then have to move somebody on or to another area, or indeed send them on with a delayed prescription that says this needs working up? So
yeah.
it comes back to that task, what we're trying to do, and then the physical area we're in, and designing the pieces around that. The second piece is, of course, if you're going to keep this running 24 hours a day, you need to take account of the fact that people are going to go on break for half an hour, and we can't suddenly stop the process that we're trying to work through. Sarah's asked, what are the handover processes between RAT and majors?
Minimal. So the patient will be taken, I mean, we're right next to each other, so the patient will be moved down. Often, actually, because we're 100% digital, it really does help, because everything is there in front of you. So often we don't need to do a verbal handover. The nurse in charge of RAT and the nurse in charge of majors often have a very brief conversation about which cubicle's free, and then sending the patient down. So actually it reduces the burden in terms of full-on handover, so that there is minimal, I would say, actually, because everything that's happened to the patient is represented in that digital record. And the nurses are really good, actually. They have these little digital forms that they fill out in RAT, so it's very clear about what they've done, what needs to be done, and similarly for the medical staff. And we've got a hand as well. So Irina.
Hello, Rich and Robert. It's Tom on the phone from actually Scan
Hi,
Hospitals.
Hey, Tom.
Nice to see you actually again. So it's more actually feedback to everyone else, because you've done quite a lot of work with us in East Kent. And I can see actually what's bothering people in other organizations, because we had exactly the same problem. Huge resistance from medical workforce, massive issue at our front door in waiting rooms, huge amount of SIs because of the delays in assessment. And it took you some time to convince us actually as well that this is the right thing. And now after a year and a half, I can definitely contest that absolutely it's the right thing to do. We have done a huge amount of work with you at the front door. We have reduced the amount of staff that we're using in major, because as you said and really well described, the workload in major area is hugely reduced if you that front door actually process right. And that's actually feedback from our staff, because before we were running rapid major assessment cubicles to 1-to-3 nursing ratio. Now with the work at the front, because we've hugely overloaded the front door with staff, we've dropped that down to 1-to-6, and staff feedback is actually, it's literally like ward-based care rather than emergency care, because that's the type of patients that goes to major, unfortunately, I think in all departments. From the front door, we have 2 to 3 initial assessment nurses, that's how we call them, and we're using combined streaming and triage. We're using ESI as a triage model, and it works really well. And all patients are assessed immediately. We have huge problem with systems that we're using, because we're using, probably you remember, multiple IT systems, and we didn't move further away from that, unfortunately, but we're still working on that. So our process is that we assess patients before we book them. So it's just slightly different. But yeah, the work that actually you've put in is great. And I would encourage everyone actually to just put the resistance on a side and just to trial it for a month. You will see the impact straight away.
Thank you, Tom. I promise I didn't send him a check before today, guys. All right. But that's really great to hear. And actually, often in this role, ECIST role, we don't, as a clinical associate, I often don't get a chance to go back and speak to people again. So it's really nice to hear from Tom that the work that we did is paying off. So that's really great. Richard, you've got your hand up because you are technically number one.
I did notice that, and when I looked, it says raise your hand. So I'm probably just completely incompetent. Sarah's got a hand up though. Let's listen to Sarah. Far more interested than me.
Hello, sorry. I feel like I'm being dead aggravated because I have a lot of questions, but I know that triage and navigation in our hospital is an issue. So I'm one of the sisters in Nottingham ED. Basically, what I'm trying to understand is, because I know this isn't uncommon across EDs, we have a real issue with crowding. So our streaming and navigation processes, I guess one of our processes is pretty similar to the RAT process that you have embedded, but that is then impacted through lack of outflow in majors. So then getting those patients through, that's where then our issues occur and the delays happen. So how I'm guessing I'll just ask, how have you managed to combat that within the RAT system?
Two-part answer. One is sometimes we haven't. Sometimes we fall over. Okay, it's not perfect. So sometimes the whole process falls over. I'm pleased to say that our ambulance data is actually very good from a sector and regional perspective, but that doesn't mean we're immune to difficulties in offloading, and doesn't mean we're immune in terms of crowding within particularly majors and RAT. A couple of things that we did and we continue to work on was to create a fit to sit area in majors. We were effectively using RAT as a fit to sit area. So we'd done everything we needed to do with them and there was nowhere to put them. So we then sat them on that RAT chair, that RAT chaired area. We moved it out. So we created a seated area right at the other end of majors, and we've dedicated 2 cubicles, if memory serves, as in and out cubicles, so that actually when they do get seen by the majors team, it's not like they haven't got anywhere to see the patient. So they go in and out because we've made a decision they're fit to sit. That's made a big difference. We are fortunate, but it's not perfect in that we can refer to SDEC, and our SDEC is multi-speciality. So when I say SDEC, I mean medicine, surgery, gynae, orthopedics, ENT, you name it. If they have capacity, then we can, and their patient's safe, they can go to that SDEC area. It is trolleyed and chaired. So actually being able to sit on a chair is not a prerequisite for the SDEC that we have. Within that envelope is also ambulatory emergency care, and they're great. They're brilliant. They take a lot of patients from us as well. So you're absolutely right. If you have few avenues out, you are going to become gridlocked. I don't know where the work is with this, but I've actually done some calls with Nottingham. I haven't physically been there. And I believe that there is opportunities to kind of really go to town on the SDEC stuff and the ground floor, I think, or whatever floor it's on. So forgive me because I've not been there. And it's those sorts of opportunities. And I know that takes time, but it's whether or not you can start thinking about the pathways now. Oh, it is in process. Brilliant. And start thinking about those processes now. So when we were creating the All Singing All Dancing SDEC, we were already thinking about, right, how are we going to maximize the use of it, and how are we going to make the best use of it? But there's no magic wand. Well, if it's in creation, Sarah, I'm sure you will be first to be there and say, right, we need to think about pathways and processes. So yeah, just have to think about that. But fit to sit made a massive difference, I have to say.
And I suppose just to add to that, crowding is one of these things that, isn't going to go away quickly. I know everybody knows that. We've been living with it for a lot of years now. And the small glimmer of, I'm going to say, reassurance is that actually, if you know everybody's been through a formal process and you've packaged them, even if they're occupying your space and staring at you, all of which is horrible, and people around, but you know that you've gone through and you've given them an appropriate designated triage category, for example, done observations to give you an objective assessment, you've got a fighting chance of feeling slightly less stressed about that part. What I appreciate is actually the rest of it is still incredibly challenging, but where possible, we really need to be ramping up those other avenues over the coming weeks, months, etc. So I'm going to draw us to a close because we've hit the buffers. Really great people got engaged and involved in it. If you want to drop us a line, please drop us a line. We're happy to have an offline discussion or a Teams call or some remote support going forward. And yeah, have a good afternoon. Keep up the great work, and may the force be with you, or whatever else you need to say.
Thank you, everyone.
Cheers, everybody.
Cheers.